السلام عليكم. بيسرني كتير اليوم. I will be speaking a little bit in Arabic at the introduction, but the entire session today for 1 hour will be conducted in English. If you have any question that you would like to ask, even if it's in Arabic, I can translate to our esteemed speaker, Monica Jacobs. So before starting, let me show you just a little bit a short introduction about what to expect today before starting our session.
Join our free webinar, Patient Safety Essentials, Your Path to CPSO Certification. Prep course exclusively offered by MEDHEALTH PRO in the Middle East and North Africa region. This course is provided by MEDHEALTH PRO at the Virtual Medical Academy. Learn about the first professional certification dedicated entirely to patient safety, covering everything from culture to process improvement. Meet our lead consultant, Monica Jacobs, an expert with extensive global credentials, and our session moderator, Dr. Rana Abdel Malak, CEO of MEDHEALTH PRO. Secure your spot for June 28th at 6 p.m. Join us online from anywhere in the MENA region. This course is provided by MEDHEALTH PRO and offered at VMA. Register today at medicalacademy.org. Join our free webinar.
So before starting, I would like to disclose that both Monica and myself, we declare that we do not have a financial interest, arrangement, or affiliation with a commercial organization that may have a material interest in the subject matter of the presentation. The presentation will not discuss the unapproved or off-label uses of medical devices, biological or pharmaceutical products. A little bit about MEDHEALTH PRO. We are a consulting and consulting, capacity building, and research and advisory firm operating two entities, one in Lebanon headquartered and the other one is offshore. We partner with hospitals, healthcare providers, ministries, and academic institutions such as VMA to translate clinical excellence into reliable evidence-based day-to-day performance. We have more than 50 years cumulative experience among our team, more than 25 high-profile expert consultants with 40% of them having terminal degree in their expertise, in their field of expertise, 10 consulting lines, 10 core training areas, and 4 research and practice areas. We are inspired, as we see, the lotus is our symbol, and it symbolizes resilience, renewal, and clarity in healthcare transformation that we provide to our clientele that we serve. Moving forward, I would like to introduce today our esteemed speaker, Monica Jacobs. Monica holds a byline of very interesting certifications and high credentials in the field of quality and safety. She's a senior healthcare quality and clinical governance executive with decades of leadership experience across complex organizations in the Middle East, specializing in patient safety, regulatory compliance, and accreditation readiness. She has successfully guided healthcare institutions through rigorous Joint Commission International and ANCC Pathway to Excellence journeys, known for translating complex standards into practical, sustainable systems. Monica combines hands-on operational expertise with strategic insight to drive measurable improvements in clinical outcomes, robust governance, and workforce engagement. So I'm very, very excited today to really be with you alongside Monica and the remaining of our attendees. This session is going to cover at least 40 minutes of a presentation that Monica has prepared to go over the structure of the CPSO certification and your roadmap for that certification. Then we're going to leave like 10 to 15 minutes Q&A and encourage you to prepare your questions so that we will be addressing all the needs for information and further elaboration about points that we covered during the session. We are planning to offer the course like late August. Monica, you're ready? Shall I stop my presentation and on to you?
Hi, Dr. Rana. Thank you very much for that wonderful introduction. And yes, I am ready.
Okay, perfect. So I'm gonna stop sharing so that you have the space. Okay, perfect.
Right. Good evening, everyone. Thank you so much for joining the session. I'm looking forward to spend time with you and to tell you a little bit about this incredible course, the Certified Patient Safety Officer course. So without further ado, let me continue. So what we're going to look at is the three domains of this course, which includes patient safety fundamentals, patient safety hazards and risks, and then patient safety compliance. The housekeeping stuff has been done by Dr. Rana, so I won't bore you with that. Right, before we get into the content, I would like to start with a question. So think of a time when you witnessed, heard, or were involved in a patient safety concern in your workplace. What happened and how was that handled? And then maybe by the end of today, you can look back on this and think, whatever happened, there's definitely room for improvement, or we are actually on the right track and we are doing things right. So let me go on. These are very, very alarming numbers. The scale of the problem is huge. 1 in 10 patients harmed while receiving care in the hospital. This is from the World Health Organization. Medical errors are among the leading cause of deaths in most countries. 50 to 80% of adverse events were actually preventable. And of course, there's always the financial burden of cost. It is just huge. But remember, these are not just numbers, because each of these statistics represent a real person, a real family, and a real healthcare team that had to deal with a preventable tragedy. I want to go over the milestones, the key milestones, the historical milestones of how quality and patient safety evolved through the years, because it's very important to know where we're coming from so that we know where we're heading. In 1999, the IOM produced a report called To Err is Human. And the numbers that they identified during this report was absolutely shocking. So just to give you an idea, 44 to 98 deaths per year from medical errors in the United States alone. So that was a huge wake-up call. And then that was followed in 2001 by the same group who did another report called the Crossing the Quality Chasm. Just FYI, these reports are actually available from the IOM site. This is a global problem because in 2004, what the WHO did then was they launched the World Alliance for Patient Safety. And then back to the US, 2005, the US Congress passes the Patient Safety and Quality Improvement Act. Although this act or similar acts was actually done in many, many other countries as well, most countries actually. And then in 2013, the Francis report, so this is from the UK, the Francis report found systemic prolonged poor care at Mid Staffordshire NHS Trust Hospital. And they found that this was caused by target-driven culture, poor leadership, understaffing, and complaints from both staff and patients that were just ignored. And this brings us to today. So patient safety is now a global priority with dedicated certifications like CPSO. What is patient safety? So the WHO defines patient safety. There are many definitions of patient safety, but let's focus on these 5 domains. So first of all, identifying hazards. You can't fix something if you can't see it. A big part of your role as a patient safety officer will be to develop the skills and the systems to identify hazards before they actually occur. Secondly, preventing accidents. Now, this is where proactive thinking becomes a huge skill. We don't just wait for something to go wrong, we anticipate and prevent. Thirdly, reducing risk. Not all risks can be eliminated. Not completely. However, all risks can be managed. Fourth, culture. Because all the policies, all the SOPs, all the procedures, all the clinical checklists, it won't help if the people who are supposed to use it, the people who are supposed to apply it, don't believe in it. So culture is absolutely the foundation of everything. So think about your own organization for a moment, and how would you rate your current safety culture? So this course is organized around 3 core domains. Now, these 3 are interconnected pillars that together form a complete picture of patient safety practices. Domain 1, patient safety fundamentals. So this is the foundation. We will look at patient safety, what it is, why does errors happen, how culture shapes safety, what is the fundamental responsibilities of the patient safety officer. Domain 2 is about safety hazards and risks, and this is where we get really practical. We'll look at how to identify, analyze, respond to hazards and risks in healthcare settings, including the tools and methodologies that we can use. And then domain 3, the patient safety compliance. And this is where you connect patient safety with regulatory and accreditation requirements. These organizations have compliance frameworks that drive and support patient safety improvements. Each domain builds on the previous one, and each domain builds on each domain move into practical hazard management that addresses the compliance and regulatory landscape. So when we start looking at domain 1, which is patient safety fundamentals, so first of all, the core patient safety concepts. I want to discuss a couple of definitions with you. Now, please note that this is not an extensive list. There are many, many, many definitions in healthcare, in patient safety, in this handbook of CPSO, in this course. So during this course, you're going to come across a lot of definitions. But let's talk about these ones first. So when we talk about adverse event, if I may give you an example, that is when a patient receives the correct antibiotic, but develop a severe allergic reaction or anaphylaxis that require emergency treatment. So that would be considered an adverse event. A near miss example would be where a nurse prepares the wrong medication, it does not reach the patient because it was caught in time by the pharmacist. A never event, these are the ones that we really, really don't want to come across. You never want it to happen. That's why it's called a never event. And they are usually very severe. In the example I use here is when a surgeon removes the wrong limb of a patient. It should never happen. It doesn't have to happen, because if you apply the correct, proper protocols, this should never happen. However, we know that it still does. And then sentinel event, an example would be when a patient dies in the care of the facility. So let's say you admit a patient with psychiatric issues and the patient commits suicide. So that would be considered a sentinel event. However, going back to the never event, that will also qualify as a sentinel event. And then just culture. So I want to elaborate a little bit more on just culture. So an example would be a nurse who accidentally administered the wrong medication due to confusing labeling. Right, so this is a look-alike, sound-alike medication, and it's due to similar looking packaging, and it was never addressed. Now, the response type, if we have a blame culture, then that nurse would be fired immediately or disciplined. But if we have a just culture, the incident is openly reported, the nurse receives support, and the system, in other words, the packaging flow, is investigated and fixed. A just culture distinguishes between the following 3. So human error, that is when the human is 100% involved, or the reason for the error to happen. And what you normally do for that is you console, you support the worker, and you fix the system. At risk behavior, what we do for that is we coach and we educate the worker. And then the most severe one, which is called reckless behavior, that's when somebody just do something even if they know that it's the wrong thing to do, and they do it anyway. And that really needs disciplinary action as appropriate. After it's investigated, of course. The key principle is that people feel safe to report mistakes without fear or unfair punishment, which ultimately improves patient safety across the entire organization. I've worked in a healthcare organization where 2 nurses were involved in an incident where they had to excuse me, administer a scheduled medication to a patient. So it was, a very high risk medication, a very, very expensive medication, apart from that as well. So what happened was, as they were checking it in the medication room, the one nurse who had the medication in her hand, it was an ampule, she dropped it. And the immediate reaction was, oh my goodness, this is very, very expensive. It was actually a medication that the patient brought from abroad. So you can imagine the impact. And it just slipped from her hand and it fell on the floor. But what happened was they immediately reported it. And because they reported it, through this reporting process, we involved the family as well immediately. And luckily, they had a family member that were coming back from that country where the medication was bought, and they could bring an alternative medication. So the hospital took full responsibility, but the 2 nurses received consoling, they were supported. And, at the end of the day, the family actually wrote a really nice report about this entire incident. And what they were really impressed of was the transparency of the hospital. So I feel very proud to share this little story with you. Right. So history, evidence, and duty of care. So what I did was I grouped some of the topics together, just so that we can talk about it in the short time that we have this evening. So history, evidence, and duty of care. Historically, healthcare often blamed individuals when something goes wrong. Over time, we learned from high-risk industries like aviation that most errors comes from the design, not from people. Evidence-based medicine connects the best available research with clinical expertise and patient values and patient outcomes. And this underpins many of our protocols and care pathways today. Our duty of care is both ethical and legal. So we must follow reasonable standards, policies, guidelines, and escalate concerns when we believe safety is at risk. The Certified Patient Safety Officer helps translate the duty of care into daily practices across the organization. Common adverse events and clinical hazards. Globally, we repeatedly see very similar patterns of harm: medication errors, falls, pressure injuries, healthcare-associated infections, delays or failure in diagnosis and treatment, especially in very busy ERs and outpatients. And then underlying these events are really common hazards like poor handover, incomplete communication, misuse or failure of equipment. Recognizing these patterns is the step towards building safer systems. Identifying events and key issues. In order to manage safety, we must first see what is happening. So we have to identify the key events through incident reports, electronic medical record triggers, audits, walkarounds, patient complaints, mortality reviews. And then when we analyze the event, we start with a clear description, what exactly happened, where, to whom. And then we explore why it happened. And I don't know if you're aware of this, but a very common practice that we follow is we do the 5 whys. So you ask why 5 times, and then you will do a really deep dive into the root cause. Looking at the policy, staffing, equipment, environment, supervision, training, etc. And then you ask which barriers or safeguards failed. What was missing and how could that have prevented the harm? Human error, reliability, and change analysis. Human error is very normal, even amongst the most highly skilled professionals. Slips and lapses occur when our attention or our memories fail, and then mistakes come from gaps in the knowledge or incorrect decisions. Reliability science aims to design processes that are consistent so that we don't have to rely on remembering, so we don't have to rely on our memories. We use tools like standardization, checklists, double checks to catch errors before they reach the patient, and then change analysis compares what should have happened with what actually happened, helping us to see exactly where the process went off track. Medication safety and pharmacy hazards. Medication safety, major focus for accreditation, regulatory surveyors, but it's also a major focus for patient safety. And this will become a very key focus for the CPSO. High alert medications such as insulin, anticoagulants, concentrated electrolytes, chemotherapy can cause serious harm even with the smallest error. Pharmacy hazards include compounding mistakes, incorrect concentrations, labeling errors, look-alike, sound-alike drug storage, etc. Safe systems use standardized order sets, clear labeling, independent double checks, barcoding, and smart pumps whenever it is available. The culture, accountability, and risk management. The overall climate of the organization is strongly influenced by culture, right? So if staff fear punishment, they will be more or less likely to report problems or speak up. In a just culture, like we explained earlier, we distinguish between the human errors, at-risk behaviors, and reckless behaviors. And then we respond appropriately to each one of them. Risk management teams often focus on investigating the incidents and managing legal exposure. Patient safety focuses on system learning and prevention. The most effective organizations integrate these functions, so incident reviews leads to meaningful changes and not just a closed file. Communication, teamwork, and leadership. I think this is one of the most important slides in this entire slide deck. Communication failures, one of the top causes of serious harm. Examples include unclear orders, incomplete handover, and assumption of who is responsible. Structured methods such as using SBAR, which stands for Situation, Background, Assessment, and Recommendation, readback for verbal orders, and standardized handover tools can help reduce these failures. Teamwork means we build shared mental models. Everyone understands the plan and the patient's current condition. We defer to the person with the most relevant expertise, not necessarily the most senior person. No, the one with the most expertise. And it's very important that to understand that leaders influence safety by setting priorities, providing resources, and modeling open and respectful communication. Patient data and the role of the PSO. Safe care begins with accurate, complete patient information. That might include, but again, it's not limited to the patient history, past history, current medication, allergies, diagnosis, risk scores like false assessment, and skin integrity. We strengthen safety when we actively engage patients and families, inviting them to ask questions, confirm their medications, raise concerns. The patient safety officer uses data from incidents, audits, indicators, patient feedback to guide where to focus improvement efforts. So domain 1 gives the CPSO the fundamental concepts, the vocabulary and the cultural understanding to lead these conversations effectively. So I wanted to elaborate a little bit on the role of the patient safety officer. The role is essentially to be a guardian of safety culture in a healthcare organization, and that's a huge responsibility. They work across all departments with leadership, clinical and non-clinical staff, patients and families. Now this will be you, because this is ultimately about the role you are preparing to take. The patient safety officer is many, many things. They wear many hats. Investigators, diving deep into adverse events and find root causes. Educators, training staff on safety practices and culture. Change agents, challenging the status quo and driving meaningful improvement. But most importantly, the patient safety officer is an advocate for every patient that walks through the door of your organization. Then we move on to domain 2. So this addresses patient safety, hazards and risks. So the first 3 that I bundled together is reporting, culture and safety assessment. An effective reporting system is absolutely at the heart of learning. Now, your effective reporting system doesn't have to be electronic. Nowadays, it's mostly electronic, but it can be a paper documentation as well. It must be really easy to use, accessible to all staff, and clearly non-punitive for honest errors and near misses. Trust in the system is very essential. If staff believe nothing will change, or they might be blamed, they will not report. So a lot of times what happens is staff report incidents and then they never hear back from the quality department. Never. They don't know what happened. So then they say, well, nothing changed. I'm not going to bother reporting anymore. So it's very important to continue that loop and give feedback to the reporter. Of course, they can report something anonymously as well, but we encourage them to provide their personal details. Safety assessment, such as proactive risk assessment, traces, walk around, it helps us identify vulnerabilities, even when no recent events has occurred. Now, this is very, very important because if you don't do this, you become complacent. So for many, many years, nothing ever happens in a certain area, but that doesn't mean that you shouldn't go there and do a proper environmental check, speak to the people there and make sure that it stays that way. As a certified patient safety officer, we encourage frequent reporting, regular assessment, and we close the loop by feeding back what was learned and what has changed. Right, then beyond the numbers and the conflicts. Traditional statistics like mortality rates, length of stay, readmission rates, very, very important, but they don't always capture safety hazards. Rare but severe events and repeated near misses may not show in routine metrics, yet they can reveal serious system weaknesses. So sometimes it's these little hidden things that just one day it comes to the forefront and you realize, oh my goodness, this can become a potential never event or a sentinel event. So risk management and quality management can sometimes appear to have different goals. Risk seems to be focused on legal protection, while quality focuses on better processes. However, it's the CPSO role to help bring these perspectives together so that we learn from events without losing sight of patient rights and organizational responsibility. Methods and incident analysis. When a significant incident occurs, we use structured methods to analyze it. We map the process step by step. We build timelines. We use cause and effect or the fishbone diagram. We look at human factors, workload, staffing, environment, IT systems, equipment designs, communication patterns. Because the goal is not to find a single person to blame, but to understand how the system set people up to fail. The key findings from an investigation should clearly identify system causes and inform practical, realistic solutions. Problem solving and improvement processes. After analyzing, you must move into action. A good problem solving process starts with a very clear definition of the problem. What, where, and for whom. You then analyze the root cause, generate potential solutions, and test them on small scale using methods like the plan, do, study, act cycle. So you measure whether the change actually improves safety or reliability before spreading it to the entire organization. These structured improvement methods prevent quick fixes because that feels good to quickly find a solution, but they are not sustainable, and they also don't address the real problem. Reliability science and high reliability. So reliability science asks, how often does a process perform as it should? In high-risk settings like operating theatres, ICUs, cath labs, we aim for processes that rarely fails because the consequences can be fatal. High reliability organizations uses standardized protocols, standardized checklists for critical steps, and redundancy when the consequences of errors are very, very high or severe. So, for example, a second person verify blood products, high-risk medications, and key steps in invasive procedures. By focusing on these systems, instead of just telling individuals, be more careful next time, we create safer, more predictable care. Prioritizing actions and strategic initiatives. Now remember, not all risks can be addressed at once. It's completely impossible. You can do a walk around and you identify 15 risks. You cannot address them all at once. So you need to prioritize. You have to analyze what is severe and what has the most potential to cause harm. How likely is it to happen and how feasible the solution may be. So the need for proactive safety efforts is very clear. If you wait until a serious event to act is costly in both human and financial terms. Strategic safety initiatives are large, long-term projects, such as reducing falls across the hospital or implementing sepsis bundles and, excuse me, and that's why it's so important that leaders must understand failures very deeply. Not just a number or a complaint, but as a sign that the system needs to be redesigned. Outcomes and central events. Improving outcomes takes time. Sometimes you bring changes in today and it can take months and sometimes even years to implement. Many factors like the patient mix, staffing, seasonality can influence results. It also involves many departments. So you can develop a program to address, let's say, difficult blood draw, but you can't do it on your own because you need the frontline staff, you need the nurses who are going to draw the blood, you're going to need the laboratory, you're going to need the IT guys for the EMR. So it's not just a one-man show or a one-woman show. You have to involve many departments, and a process like that can really take time. That's why continuous monitoring and adjustments are essential. Central events, like we spoke about earlier, death or serious permanent harm, those events really demand immediate in-depth review. Regulatory bodies and accreditation surveyors will expect to see a structural investigation and an action plan for sentinel events. And teamwork is critical. Different professions contribute different insights into what went wrong and how to prevent recurrence. Right, so domain 3. Sorry, let me just take a sip of water. So patient compliance. Let's start off with outcomes and sentinel events. So in Saudi Arabia, the CPAHI, I'm not sure how you pronounce that. I know it's something like Sabahi or something. I'm not sure. Please excuse my pronunciation. But that's the main accreditation body. However, many organizations align with international standards like Joint Commission International. These standards really embed patient safety expectations in areas such as medication management, infection prevention, falls prevention, incident reporting, etc. And also competency of staff. Common adverse events like medication errors, infections, falls, pressure injuries, and diagnostic delays are all targeted by these standards. Diagnostic errors, whether a misdiagnosis or a significant delay, has a major impact on patient outcomes, and it's really an increasing area of focus. Environment of care and emergency management. Accreditation standards emphasize the environment of care. So under that umbrella, fire safety, safe utilities, medical gases, water, physical layout of the hospital, etc. If the environment is cluttered, poorly lit, badly signed, patients are more likely to fall or experience delays in care. Emergency management, very important, a huge patient safety issue, especially if you think of the recent unrest in the Middle East. It is a huge patient safety issue. Clear patient evacuation plans, well-defined staff roles, and regular drills help ensure that even under stress, we can move and care for patients safely. So in one of our hospitals 2 years ago, there was a huge flood and the entire hospital had to be evacuated. Now this hospital is, they were in the process of building an extension hospital, which is a block away from the original hospital. And the patients had to be, some could move with an ambulance, but the roads were so flooded that staff carried the patients through the rain to the other hospital. One patient that were removed from ICU on the way down from the stairs, because the ICU is on the second floor. So going downstairs, the patient arrested. They successfully resuscitated the patient and the patient survived. So they didn't lose one patient or staff member in this flood. It was an absolute, it was just to look at because somebody took videos protecting patient rights and responsibilities. Of course, no patients' faces were shown, but you get emotional when you see how good the team worked together to evacuate these patients safely. So I just wanted to share this little story with you. Right, infection prevention and hazardous drugs. Infection prevention is a core safety and accreditation requirement. Healthcare-associated infections increase morbidity, mortality, and cost. They damage the public's trust in the hospital. Effective programs focuses on a very simple but a very complicated and a very difficult thing to implement, which is hand hygiene. Proper isolation, device-related bundles, and robust environmental cleaning. Hazardous drug safety plans are essential for protecting staff and patients, of course, from exposure, especially with, for example, chemotherapy, certain antivirals, and the cleaning materials that we use. These plans address safe preparation, labeling, transportation, administration, and disposal, and they are scrutinized during accreditation surveys. Sorry, I just need to switch my laptop on because it's dying. Right, medication, equipment, and falls. Safe medication management covers the entire pathway: prescribing, verifying, dispensing, administration, and monitoring medication. Accreditation and regulatory surveyors will expect clear policies on high alert and lookalike sound-alike medication, as well as documented medication reconciliation. Medical equipment safety directly affects patients. Equipment that is poorly maintained, incorrectly used, can cause significant harm. And then hospitals must have robust programs for fall risk assessments, tailored interventions. Falls is one of the most common and highly visible safety metrics. Support personnel and patient safety organizations. Patient safety is not a clinical responsibility only. Housekeeping staff, porters, maintenance staff, security staff, everyone contribute by maintaining a safe environment and reporting hazards. See something, say something. Everyone must understand how to escalate concerns and whom to contact when they identify a safety risk. Communicating safety issues can be difficult when there is fear, hierarchy, confusion about processes, and if you have a blame culture. And that is a key task of the certified professional safety officer, to simplify and normalize this communication. Right, so why should you do this course? The certification is issued by the International Board of Certification of Safety Managers, specifically for leaders in healthcare safety. Now, who is a leader in healthcare safety? Everyone. The eligibility designed for practitioners with at least 2 years of hands-on real-world experience in healthcare. Exam focused, the assessment moves beyond simple memorization, and it's designed to test critical thinking, situational analysis, and the practical application of safety principles. To support candidates, there is a free certification practice test included to help build familiarity and confidence. And as a voluntary and prestigious credential, it serves as a formal validation of your expertise. Ultimately, it's not just a test, it's not just a certification, it's a tangible demonstration of your professional commitment to patient safety and operational excellence. So what will you learn? So the master core pillars of patient safety: safety leadership, learn to lead people, not just to manage processes. Accident causation, identify root causes before harm occurs. Human factors and errors, understand why people make mistakes and how to prevent them. Incident prevention and analysis, pinpoint system failures and fix them proactively. Ethics and accountability, you build a culture of trust, transparency, and responsibility. What will it do for you? It will advance your careers. You will stand out as a recognized patient safety expert. It will reduce risk, apply proven strategies to prevent accidents and injuries. You will lead with confidence, engaging teams, drive safety culture, and earn trust. You will cut organizational cost. Fewer incidents means better resource utilization. Make a real positive impact. Protect patients, protect staff, and your entire organization. So this is the architectural clinical trust, or the patient safety officer's blueprint. So domain 1, which is the patient safety fundamentals again, build the foundation of safe, high quality care. Domain 2, patient safety hazards and risks, spot, assess, and eliminate dangers before harm can occur. And then domain 3, patient safety compliance, turn knowledge into accountable standards-driven action. This course will equip you with the knowledge, awareness, accountability to lead patient safety, protecting patients, protecting staff, empowering staff, strengthening the organization. So it gives you the knowledge, the awareness, and the accountability to lead patient safety with confidence and make a lasting difference to your organization. And that is it. So the floor is open for questions.
Thank you so much, Monica, for this very elaborative dive in the CPSO certification roadmap. I believe our audience has been very enthusiastic all through your presentation. We had pouring of questions that I have answered in real time, particularly one question about interns. Are interns who did not yet graduate eligible to sit for the certifying exam? And I believe your slide has answered, but can you elaborate a little bit on that?
So this course is basically for everyone. This is the beauty of this course.
Mm-hmm.
If you just start, getting into healthcare, no matter in what position, patient safety is everybody's business, and this course will lay the foundation. There's a lot of information, but it's presented in such a way that it's very, very applicable. So even if you are not a clinical staff, you can actually apply what you learn from this course. I hope that answers your question, Dr. Rana.
Yes, it does. The problem that I believe was the issue in the question is that the person did not yet graduate with a professional degree yet. So I believe they need at least 2 years of
Yes.
experience with a professional degree, be it nursing, pharmacy, physician, radiology, MLT,
Yeah.
laboratory. Any healthcare professional who is practicing in healthcare with a professional degree, a license can, after 2 years of solid experience, proven solid experience, they can sit for the test, for the certification test. But to elaborate on your answer, Monica, is that anybody who sits for the prep course can benefit from the information regardless if they go through the certification exam, yes or no. Because these are foundational information where patient safety is everybody's business, not one person in one isolated place in the hospital. And even across the continuum of care, I believe, from
Yeah.
the ambulatory setting to clinic setting to acute care to rehab, patient safety really transcends the entire continuum. Wherever there is a patient, there is safety attached to it. So definitely in hospitals and tertiary care, the content of the course is much more prominent and more applicable because it really addresses those areas that are high risk, but it does also apply everywhere. So one question before we close, and this gives us the opportunity to clarify. We have pouring of thank yous. Monica, that was very well received. Thank you so much for all the diligent work related to the content. So the question is to really clarify to our audience the added value of CPSO and versus CPPS, because I believe you are a CPPS. And there is also the CPHQ. So we're much more concerned to really clarify to the audience very simply, very briefly, the difference between the two so that they really get hold of the added value of sitting for the CPSO.
Dr. Rana, thank you for that question. I'm going to relate to myself. So when I stepped into from a registered nurse, I stepped into the world of quality, and I realized that although I have a strong clinical background, I didn't understand the nuances of understanding how what we do have patient, how it affects patient outcomes. If this was back in 2011, if this course was available, I would have done it first because I feel this lays the foundation. The first thing I did was CPHQ, and to be honest with you, it made no sense to me. It was way above it was way above what I understood at time. This course is really, for me, laying that foundation of this will make that decision for you. You know, which direction do I go? Because what I really love about this course, it addresses environment of care. So if you feel that you know, rather want to be a safety officer, environmental, occupational health and safety officer versus a patient safety professional, this course will guide you in that direction because it addresses everything. Do you want to explore risk management? You know, if that domain then appeals to you, then it will really guide you. So I feel that this is a great foundation. It's like a compass. It will point you in the right
I believe.
direction.
Yeah,
Yeah.
I think this is the. I think we cannot put it better than this. This is the really the compass of patient safety and the foundation of patient safety. Before you really go higher into that direction and be in quality systems, like it's a stepping stone for you that is built on like solid foundation that is evidence based, while you gain the certificate for your career. And you
Yes.
start building up on advanced level with other courses that are much more specialized when you deep dive into your career into those tracks. So we wanted really to ensure that this clarification is made. They are not equivalent. They are a way. It's a stepwise approach, starting from the foundational course, which is the CPSO, to the other higher level courses. Let's see, we have comments in the chat. Let me check if we have. Still, we have a lot of good feedback from our audience. Everybody has really received. Okay, we have another question from Ali. What is the most common patient safety mistake you see among newly graduate doctors, and how can we avoid it?
Wow, this is a great question.
Excellent.
Many things comes to mind, but from experience, one of the most common errors that newly graduated doctors make is they don't do proper patient education. So remember, patient education starts with admission. So that will include taking a proper patient history. And I found that they don't have the, I can almost say they haven't developed that gut feeling yet, you know, or that gut instinct yet of, you know, the patient answers something but don't answer something. And then they need to explore that more. So I think that is one of the most common things that I see amongst newly graduated doctors.
I also see one more, if I may add. In my practice, I used to see doctors skipping steps in
Yeah.
identification and related to patient safety goals as well. Like, especially in when we are talking about laterality, proper patient identification. So these are not very common, as Monica has said or gave the example, but they are the never to happen incidents. So we don't want those incidents because they are very highly risky to be if you miss the step, you will end up in a big problem. So that's why it's very important not to.
So
So let's.
actually, Dr. Rana, if you know, if I may, from
Yes.
what I said and what you said, I think the most common area is communication.
Yeah, yeah, and this was, by the way, researched by John Commission, and they have really traced back the number of incident, the sentinel events, and the root cause of sentinel events. I have that piece of information in one of the courses that we gave, and around 70% they funnel down to poor communication among healthcare
Yeah.
workers.
Yes.
So that's very true what you're saying. Habiba, thank you. The lecture was highly informative and again valuable knowledge. Thank you, Habiba, particularly in the area of medication safety. We have a course for CMSO if you are practicing as a pharmacist. If not, this one would be much more helpful for you. Abdel Latif, please explain for the isolation patient safety. So if you can elaborate a little bit about that point under the CPSO, what does it cover? Isolation and
Oh,
infection control and things like that.
Okay, so isolation measures means that once a patient is, identified or diagnosed with a communicable disease or a highly infectious disease, they need to be isolated. So isolation patients, there are certain standards. So the infection control preventionists, they are, they need to be consulted on the isolation protocols that needs to be applied. So isolation protocols might be, droplets, or it can be
Respiratory
airborne. So it depends
contact.
on the patient's diagnosis. So that's what we mean by the isolation protocols.
Another question, can you explain culture of change initiative regarding Saudi Arabia health system? I think this is beyond this webinar, but we can really hint a little bit on it.
Yeah, so culture change is not really, I think it's not defined by the country. A culture change system needs to come from leadership. So it's very, very much a top-down change that needs to happen. And again, I can speak from experience. I was affiliated with a healthcare system that was in a lot of trouble when it came to ethics and compliance, and it really needed a huge culture change. And actually, what happened was that the entire senior leadership decided to change the values of the organization. When you look at the mission, vision, and values of any organization, it's very similar, integrity, but they decided to go a completely different way, and they added ethics and compliance as one of the very first things in the values. And the CEO actually went on a roadshow to spread his message, because the organization needed a huge culture change. And he made sure that all leaders attended training focused on how do you address a culture of blame? How do you address a culture of punitive behavior? And everywhere there were posters of speaking up, and everybody bought into the idea. And that was the whole idea, So in order to do that, you need strong change agents. So that is why one of the roles of the CPSO is also to be a change agent.
True.
You need the change agents to drive it, to be on the floor, to keep their ears open, to listen for what's happening, and then address any negativity immediately. It takes time to change culture. It takes a lot of time. It's not easy. And unfortunately, even some people can walk away from an organization and they can say the culture never changed. But that rarely happens, because if you really work hard, if leadership and then everybody works hard to change the culture, it can happen.
Yes, culture change usually takes a lot of time. Studies they do monitor the time, and some of them they have reported that if you have at least like the basics foundation available, you need 5 years to change a certain culture. That's with the foundation. We're not speaking like starting from below the foundation level. Okay. We're having a lot of good, a lot of pouring of thank yous. Thank you all. And the question from Haya, I think in relation to the evaluation of the event, you can put both your level or your profession. Better if you put your profession in the evaluation, Haya. That was for the evaluation form. If nobody has any more questions or concerns or comments, we may just close because we're up to the hour. Okay, thank you so much, Abdul Latif. Thank you for attending. Thank you, Wajd. We hope to see you all in the course. The full course, the full preparatory course will be offered end of August. We're still debating the date, the final date. I believe we're leaning towards the last week of August, right, Monica? end of August. So the full course, the full preparatory course for 30 hours will be offered by MEDHEALTH PRO, by our esteemed speaker, Monica Jacobs, and will be presented through VMA. So I believe we don't have any more questions. Thank you, everybody who joined us this evening. Thank you again, Monica, for the great webinar. We're having a lot of still pouring of feedback, positive feedback.
Thank you so much. Thank you, everyone, and thank you for your kind words and the really, really nice questions as well. And I'm looking forward to see all of you.
See you all in August, hopefully.